when you bring data and this type of evidence to payers in the US or even across the globe, I don't know if you've actually done that yet, Trish, and the rest of your team, what do they say? Are they just blown away and go like, oh yeah, we definitely have to fund this. This makes like complete sense. Or are they much more resistance? There's still a lot of resistance. Like, well, where do they fall? And I'm sure there's a spectrum, but
Yeah, there is a spectrum. I've definitely encountered some payers that have said exactly that. Oh my God, this makes a ton of sense. And they change their coverage policies right away. It's more common, however, for payers, whether they're government payers like Medicare or Medicaid or a commercial payer here in the United States, to take a more thoughtful approach. And they really want to look at the evidence to ensure, number one, that there is clinical utility, that there are actions that can be done. It's not just information for information's sake, that it's actually going to have the potential to change the healthcare trajectory for that patient. So they really want to see a lot of data. Secondly, they want to understand that it's cost effective. And so I love Britt's example of the bone marrow transplant, but that's just one of many treatments. Sometimes it's inexpensive medical food or supplementation, or for many epilepsy patients, it's adherence to a ketogenic diet. And so, not all treatments for genetic disease are something like gene therapy or a bone marrow transplant. So, that's another hurdle that we have to explain to payers, that this is actually cost effective, that there are many things that can be done for the family to change medical care, to improve what it is that they need to have done for their child. And we also want to make sure that we're getting evidence not just for the payers, but also the clinicians need to be convinced. We've got the guidelines around testing are relatively new. They American College of Medical Genetics and Genomics came out with their guidelines recommending exome and genome testing as a first tier diagnostic approach in 2021. And just this last summer, we had the American Academy of Pediatrics say, hey, pediatricians, you should be ordering this as a first tier as well for these patients. And so we're at the beginning of a long climb of educating those healthcare providers, as well as the health systems that they work in. We want to make sure that the health systems themselves are aware of how this is going to benefit their family. And then, of course, we can't forget the regulatory bodies that are overseeing everything. They want to make sure that the evidence that we have shows that the test is safe and effective for people to utilize. So, our market access team combined with Britt's team, we have a lot of work to do to generate evidence and the right information in a very parsable and meaningful way for these different agencies.
and would you say that it falls more in the utility side that's still the resistance, or do you think it's more the cost component that still trips people up, at least in this case, the payers?
In my opinion, it's still both, because there is still a healthy skepticism. Do we really need to sequence the entire genome to find out the answer? And the answer is yes, we do. We studies have shown that panels, while valuable for some patients, are less effective for some of these children that are just we know it's genetic based on the constellation of findings that they have, but it doesn't fit a neat syndrome. The differential is so large that you cannot go panel by panel or gene by gene. It's just not effective to do that. So there is the skepticism there. There is also the belief that, wow, this is really expensive technology, and the costs are coming down. It's definitely becoming more affordable for families, for clinicians, for the healthcare system overall, for payers.